Good morning, everyone. My name is Louisa Boswell, and I am a second-year medical student at VCU School of Medicine. This summer, I worked with the VCU Department of Family Medicine and Population Health on a research project involving opioid use in Virginia, and today I would like to share some of this work with you. As many of you already know, the opioid epidemic continues to escalate both nationally and within the state of Virginia. In 2021, over 2,000 Virginians died from opioid overdose, and that corresponds to 6 patients per day. Now getting into the work that I did with the Bright Spot Project. While previous research largely focuses on areas with high rates of mortality, the Bright Spot Project uses a strengths-based approach that aims to identify areas where mortality is actually less than expected. So our team began by conducting a multivariate analysis that identified factors correlated with mortality, and then using those findings, we made a predictive model. Outlier communities or areas where mortality was actually less than predicted by the model were then identified as bright spots. So here's a map of the 20 bright and cold spots identified by this analysis. Blue dots are going to represent bright spots and red dots are going to represent cold spots. And the size of the dot is just an indication of how different the actual mortality value was from the predicted value. So then our attention was drawn to these big blue spots because these are communities that had significantly lower mortality rates than would be expected based on our model. So the next logical question is, what's going right in these communities and how might we be able to learn from them? So the project's next steps are to go into these communities and conduct qualitative interviews that might provide insight into the uniquenesses of the communities and why they might be doing better than others. So my specific role in the project was to develop an interview guide, and in doing so, I spoke with a diverse group of professionals in the field, and my conversations informed and shaped the guide that will be used in the next step of the project. So I'd now like to share some of the common themes that came up in my conversations. So most of you are probably already familiar with the evidence-based concept of MAT, or medication-assisted treatment, now referred to as medications for opioid use disorder. In recent years, the main focus has been ensuring the accessibility of MAT. However, I found that even when medications like methadone, Suboxone, and buprenorphine are available, there are community barriers that are deterring their usage. For instance, prominent recovery programs like AA and NA appear to be variable in their acceptance of MAT. So according to the NA model, a person using a medication for an opioid use disorder is in fact not considered to be in recovery, which is, as you can imagine, can be alienating and isolating for the individual seeking treatment. That being said, this attitude can vary program to program and community to community, making it an interesting target of further qualitative investigation. Community buy-in also came up in the context of law enforcement, where I learned that drug courts and prison systems are also inconsistent in their acceptance of medications for opioid use disorder. Another theme that I gleaned from my conversations was the importance of integrative care models. Everyone that I spoke with enthusiastically endorsed the OBAT, or office-based addiction treatment model, because it allows individuals to seek treatment for their opioid use disorder in a context that they're already familiar with, like their doctor's office. Family medicine physicians are going to be well suited to this role because of the longitudinal relationships that we build with patients, as well as our holistic consideration of the patient, their motivations, their family, and their community. We also know from our prior multivariate analysis that a higher number of mental health diagnoses correlates with a greater opioid mortality, and so it's crucial that we work with interdisciplinary teams of clinicians and behavioral health professionals to address not just the physical health, but also the mental health of patients. A final theme that came up in my conversations was the importance of peer leadership in the recovery community. So certified peer recovery specialists are individuals who themselves are in recovery, and they're specifically trained to work with patients on developing recovery management plans. These specialists are able to meet patients out in the community, build trusting relationships, and relate in a way that many healthcare providers may not be able to. Despite substantial evidence supporting the use of peer recovery specialists, occasionally there are complications with billing since these individuals are often not certified behavioral health professionals, and so this is another important area of continued research. So that's all I have for you today, but I would like to thank my mentor, Jackie Britz, and the Family Medicine Department at VCU, as well as DMAS for their support of this study. I'm happy to take any questions, and also feel free to connect with me via email. Thank you for your time and attention.